All right. Like I said, we got a lot of great stuff for you today. So I want to get started here so that we keep it all within the hour and don't take too much of your time. Again, thank you all so much for joining us for today's CO-APCD Research Showcase. Um, and I'm going to just do a quick introduction to give you a little bit of background information about us here at CIVHC and the Colorado All-Payer Claims Database. And then we'll get into the real reason you're here, which is to hear from our two fantastic presenters. So, just to start off, here's a quick bit of background on CIVHC and the COABCD. Next slide, please. Um, CIVHC is a nonprofit. Our mission is to equip partners and communities in Colorado and across the nation with resources, services, and unbiased data that's needed to improve health and healthcare. We believe everyone should have the opportunity to be healthy and have access to equitable, affordable, and high quality healthcare. Again, as I mentioned, we are a nonprofit. We are therefore independent and objective, and focused on service. And again, we are the administrators of the Colorado All-Payer Claims Database. We work with a lot of people throughout the spectrum of healthcare. Anyone who is working to improve care or lower costs, that is somebody who we want to partner with. So that takes us across from working with facilities and hospitals, employers, nonprofits, and government entities, consumers, health plans, and today you're going to hear from one of the researchers, one of the many researchers who we work with. Next slide, please. The way that we partner with all these folks is essentially twofold. Again, as the administrator of the COAPCD, we release public data on our website on civic.org for folks to identify opportunities to improve healthcare in their community. This is data that anybody can access for free. We have public data that covers a wide variety of topics. That is everything from telehealth utilization in Colorado, use metrics, price transparency tools, adoption of APMs, prescription drug data. So please go and check out some of our public data on our website. If you get a chance and you're able to request the underlying files for the majority of our public data reports that we have. We also license CoAPC data to data users. So that is folks who are working in research or want performed analytic services. We also perform evaluation and research for certain partners and engage directly with the community. And one thing I did want to mention very briefly is that a new report that we have that is able to be accessed for licensing is our hospital price transparency report. This is data that is taken from the publicly posted hospital price transparency. Every hospital, as most of you know, has to post public price transparency data. And so we took all of that data from over 80 facilities across the state and cleaned it and sort of condensed it into CSV files that are able to be downloaded, and so you can see licensing and pricing data for hospitals all across Colorado. So it's a very useful resource. Please go check that out on our website as well. That's something that we're really excited to be able to do. Next slide. This is my last slide before I turn it over to our two presenters today. This is just a quick look at what is in the Colorado All-Payer Claims Database. We have over 1.3 billion claims now, which is a lot, spanning from 2013 to 2025. There are 33 commercial payers represented in the database, as well as Medicaid and Medicare fee-for-service and Advantage. That represents about 70% of covered lives in Colorado and over 5.7 million lives. Some things that are not in the COAPCD, federal program data, so that is VA, TRICARE, or Indian Health Services data, we do not collect. We also obviously are unable to collect uninsured or any self-paid claims. And finally, we do not have the majority of ERISA-based self-insured employers. They are not mandated to submit data to the COAPCD. So they submit on a volunteer basis, which means we are unable to collect all of the data for self-insured employers. However, we estimate that we have about 50% of self-insured employers represented in the CO APCD. So, with that being said, I'm going to turn it over to Chiara, who's going to talk to us about the research that she has been using co-APCD data to perform about physician incentives and vaccine uptake. So, go ahead and take it away, Chiara. I'm excited to hear about your work.
Okay, so thank you very much for the invitation. I'm Chiara Gardenghi. I graduated from NYU last year, and I'm currently a postdoc at the University of Rochester, Simon School of Business. And broadly in my research, I am interested in the industrial organization of healthcare markets. So today I'm excited to present my work, which is bundle loyalty discounts in healthcare, evidence from physician-administered vaccines. And so in this project, I use basically the Colorado APC data to examine the contractual arrangements between pharmaceutical companies and medical practices and to learn how they shape physician administration of vaccines in the US. Okay, and let me start with the motivation for this project. So, as we know, pharmaceutical companies are often multi-product firms. And with this, we mean that they can ultimately leverage bundling strategies to push the buyers to buy multiple products from them in exchange for discounts. And bundling of drugs have really become pervasive over the last few years. Here I list a set of antitrust cases that all dealt with bundling of drugs across different markets, across different diseases. And the outcome of these antitrust cases really depended on the specifics of the markets of interest and the specific of the contractual arrangement. So the outcome of these antitrust cases was really heterogeneous. What I want to emphasize on top of that, let's go to next slide, please, Spencer, is that there is a broad class of drugs that are the so-called physician-administered treatment that you may be already aware of. There are a broad class of drugs which include infusion for oncology, arthritis injection, and for sure vaccines. And the peculiarity of this drug class is that physicians have to choose which and how many drugs to purchase from manufacturers or through intermediaries, which drugs to store in their offices and then administer to their patients once they arrive. So there is what economists usually call the typical agency issue, in the sense that in making these choices, physicians have to weigh on one hand patient health and on the other hand their own financial incentives. So what I'm going to show you today is how bundle loyalty discounts can further influence physicians' decision in this context. And let me close my motivation by also emphasizing that to answer and to study this question, I face an intrinsic data challenge, which is that typically the contractual arrangements between pharmaceutical companies, so manufacturers, and physician practices are proprietary, so we don't observe them. And so what do I do in this project? I basically combine two data sources, two sources of information, which are one, antitrust cases from which I learned the specific contracts between pharmaceutical companies and medical practices, together with claims data from which I observe the actual purchasing and administration behavior of physicians. Okay? And so, in concrete, what are the research questions that I will be trying to address today? So one is, how do drug manufacturers' bundle loyalty discounts influence physician decision on which and how much treatment to purchase for their patients? And two, what are the welfare and health effects from having versus banning these discounts? And so the welfare trade-off that I would like you to think of throughout this presentation is the following: that in the presence of discounts, physicians will be more likely potentially to buy everything from a single manufacturer, okay, to qualify for these discounts. And so we may be wondering what are the quality consequence of this action, meaning are really physicians choosing the best available treatments on the market, or are they choosing drugs just to qualify basically for these discounts? And as a result, are physicians excluding automatically any manufacturer selling even superior drugs? But on the other hand, instead, I want to emphasize that these contractual arrangements can also prove to be welfare improving. And why is that the case? Because in the presence of discounts, physicians will ultimately end up paying less for this class of treatments, and so they will tend to increase potentially the purchase of those treatments, okay? And this is positive for patient health if we think of all these drugs that are underprovided, that are typically underprovided, as it is the case for vaccines. Okay, let's go next. Okay, and so what I will be doing in this work precisely. So first I will document physicians' adoption of these bundle loyalty discount contracts for vaccines purchases. And I will be able to show you that by really exploiting antitrust cases to learn the purchasing rule that physicians have to meet to qualify for discounts, and then go to claims data to instead observe physicians' actual vaccines purchasing and administration, and to check whether this is compliant with the discount rule. Second, I will be building a model for physician demand and manufacturer supply of vaccines. My context of interest is going to be the market for pediatric and adolescent vaccines in Colorado. The key parameters I will be estimating from the model are physician sensitivity to the financial gains, as well as discount magnitudes, for which we have only averages number from the antitrust cases. And the key variations in the data that I will be exploiting and that I will be talking about in a sec is really the fact that physician practices have a heterogeneous pool of patients, both in terms of the age of these patients, meaning different needs for vaccines, and in terms of heterogeneous insurers that cover these patients. And second, the second source of variation in the data is really a merger that happened throughout my time span of interest that changed the manufacturer's portfolio of products that they can sell, and so the discount rule, basically. Finally, as a third point, I will build and simulate a key counterfactual scenario, which is what would happen if we were to ban this discount, an outcome that can result from either regulatory intervention or antitrust, intervention. And so let me give you a preview of these results. So basically, if we were to ban discounts, manufacturers will be optimizing again their prices, and they will tend to set prices, newer prices, which are typically higher than the discounted ones, okay? And so physician practices that were relying a lot on these discounts when present are gonna now tend to pay more for the same amount of vaccines. And so they're gonna be more likely to modify their purchasing behavior in two ways, in two directions. First, they're going to tend to reduce the administration of vaccines, especially the optional one, the ones that are not required to kids to access school by state law. And if two options are available, two vaccines option for the same disease, they're going to tend to go for the cheaper one in this world in which everything is more costly. But in the world of vaccines, at least based on clinical trials data, we know that cheaper options are typically lower quality in terms of more adverse effects and lower efficacy, okay? And so overall, this means that at least in my context, a discount ban would make patients and physicians worse off because they're gonna get less shots basically and lower quality shots. Physicians are gonna be worse off as well because they will not basically take advantage of the opportunity to gain for each shot because of the margin that they make on each shot. Insurers, at least in the short run, are gonna be better off because they're gonna basically cover less shots, okay? And for manufacturers, the implications are ambiguous. They face both a higher price that they're able to earn for each shot, but also a market shrinkage effect. And so which of the two prevails will ultimately depend on the portfolio of products that they have. Okay? And let me show you in concrete the market that we are studying. So here is the market for pediatric and adolescent vaccines in the US as of 2014. As you can see, there are multiple vaccine types, multiple diseases, and multiple manufacturers that produce brands for each disease. And so there are a couple of takeaways that I would like you to take away from this slide. So the first takeaway is that vaccines are split into the required one that are required by Colorado law to access school versus the optional ones. The second takeaway is that for each vaccine type, for each disease, there are usually a couple of options, a couple of brands sold by two different manufacturers. For example, for diphtheria, tetanus, and pertussis, we have both the GSK brand and the Sanofi brand. And if two options are available, I want you to think of them as both vertically and horizontally differentiated, meaning that usually one of the two brands is newer, meaning higher efficacy, lower adverse effects. And also doctors may have a preference for one or the other because they imply less doses to be injected, easier, more convenience in administering really the shot, and so on. Finally, the third takeaway is from the next slide, actually. And from this slide, you can see that over my time span of interest, there were some changes in market structure. This is the situation up to 2016. And so what I'm showing you here is that Novartis, which was producing before 2016 the meningitis brand together with Sanofi, sold its meningitis brand to GSK. So GSK acquired the previously Novartis brand and start basically bundling this newly acquired meningitis brand with the other vaccines, okay? And this is a sort of heterogeneity and variation in the data that I will exploit for estimation. Let's go with next slide. Okay, and so now I'm ready to give you an example of how these contractual arrangements work. So here I have a very simplified example with just 3 vaccine types and 3 manufacturers. Each of the brand has its own list price before discount. And let's suppose you are a physician practice that needs vaccine type A and B because you are mostly focusing on babies. So you don't need vaccine type C because C is mostly for adolescents, for example. There are several options you can choose from. Option 1 is, for example, you buy everything from manufacturer 1, okay? And if this is the case, then you're gonna basically qualify for sure for discounts from manufacturer 1, and you're gonna pay a discounted prices on all the shots you receive. Option 2 instead is you buy vaccine type A from manufacturer 2 and vaccine type B from manufacturer 1. And by doing so, for sure, you do not qualify for discount from manufacturer 1, but you do qualify for discounts from manufacturer 2 because conditional on what you need to buy, you're buying everything manufacturer 2 has in its portfolio of products. And then there is an extreme case, case 3, which is manufacturer 2 and 3 are so complementary in their product portfolio they're offering that you end up qualifying for discounts from both. The purpose of this exercise was just to show you that you have multiple options, and what you will ultimately decide to do will depend on the size of the discounts, clearly, the list price and the doses that you need, but also on how much a physician practice weights the financial incentive against other brands' attributes, like, for example, the quality of the product. And these are going to be the key forces that I will account for in the model. And let me now go to give you an overview of the data I'm using. So as mentioned, most of my data are basically the Colorado APC data. So from the data set that I extracted, I'm basically able to observe patient-physician interaction over time. My focus is going to be on in-office vaccine administration. I'm able to construct primary care practices indicators because very wisely the Colorado data reported basically the billing NPIs associated to each service NPI, meaning that I can really map each service provider, each doctor usually doing the service, to the organization it belongs to and see how this change over time. I validated this measure across other data sources and confirmed that this is actually a really good measurement. What I observe, moreover, is the vaccine brand administered. I'm able to recover it through the CPT codes and the related manufacturer through NDC codes. I observe also insurance reimbursement given to physicians. What I obviously do not observe is the actual price paid by practices to manufacturers to purchase vaccines. And so for this piece of information, I turn to publicly available data from the CDC to learn about the quarterly list price before discounts set by manufacturers for each vaccine brand. The discount instead is going to be estimated from my model. Okay? And with this data, I'm going to show you a couple of empirical facts. If we can go to the next slide, please. So the first fact that I'm showing you here is that a large fraction of practices meet the discount requirement for procuring vaccines. And I'm able to say that because I know manufacturer vaccine portfolio, I know their discount requirement from antitrust cases, and so by observing physicians combine vaccine choices from the Colorado data, I can determine which practice are discount eligible. For example, as of 2014, I can see in the data that around 18% of my practices are compliant with the GSK discount rules, around 38% of my practices comply with the Merck discount rules, and so on. Fact 2 instead shows you that practices patient age mix predict very well the manufacturer practices are going to basically buy from the entire pool of vaccines they need. And the idea here is that practices vary in the patient age distribution they have. For example, some practices tend to focus more on babies, while some other practices tend to focus more on adolescents. Now, vaccines are strongly linked to an age schedule. For example, DTaP is typically given at 2-month-old. And so this means that if in your practice you have a lot of 2-month-old babies, you're going to need a lot of DTaP shots, which means they're going to be more likely to buy DTaP shots and all the other vaccines that you need from manufacturers that sell DTaP products in their portfolio, and thus to qualify for their discounts. And I'm testing this empirically with a multinomial logic examination here. And finally, let me go to fact 3, which is about the merger, basically, that I was anticipating at the beginning. So what I'm showing you here is that changes in manufacturers' vaccine portfolio affect practices' choices. So before 2015, there were 2 meningitis products available, the Novartis and the Sanofi one. In 2015, there was a merger, so GSK acquires all the vaccines, and so the meningitis vaccines that Novartis had, and GSK was now able to bundle basically the newly acquired meningitis with all its other with all its other product. Okay, and so what you can see on the left in this picture is that practices that were already loyal to GSK, that were already receiving the discount from GSK before 2015, the solid line, now are more likely to purchase the newly acquired GSK meningitis brand rather than the competing meningitis product, okay? Really because they need to stay compliant, they want to stay compliant with the GSK rule, and so in order to do that, they have to switch to the newly acquired meningitis product, okay? And so with this, I'm moving to give you an overview, a sketch of the empirical model that I'm taking to data. Broadly speaking, my decision makers in this context are going to be practices that are maybe mostly primary care practice in Colorado. Each practice is endowed with a pool of eligible patients based on the age, namely kids that they expect to get the vaccine shortly. A brand J is a vaccine type manufacturer combination. So for example, a brand is rotavirus GSK, but what ultimately the practice has to choose is a basket B, namely a combination of brand, a vector of brands. And just to give you an example in the next slide, I'm showing you that an example of basket that you can pick is the vector composed of all the green dots. So for example, a basket is diphtheria GSK, measles, mumps, rubella, Merck, and so on, okay? And so just to give you an idea, let's go to next slide. The demand side of the model is going to face practice high, choosing a basket is preferred basket, delivering the highest utility. What's the basket utility? The basket utility is the sum of the utilities associated to each brand included in the basket, plus a basket-specific complementarity terms, namely a term like the discounts that the practice can get if the basket that the practice selects qualify for the discounts, okay? What's instead the component of this basket utility, so the utility associated to a single brand inside the basket, is the combination of the financial gains that the practice get, namely the difference between insurance reimbursement and purchasing price paid to manufacturers, and non-financial gains, such as, for example, the brand quality or convenience. So from estimating demand, I can recover the discount magnitudes, which happens to be between 10 and 25% of the list price of each brand, and practice elasticity to financial gains. On the supply side, instead, I face multiple manufacturers which sell multiple products and competing prices and discounts. I will be able to write down first order conditions and basically estimate marginal cost from there. Okay, and let me close now with the final exercise. Ultimately, the purpose of the model is to try to simulate a scenario in which we instead were to ban discounts. This can result from either antitrust action or policy intervention. For example, as of 2019, the first Trump administration was proposing a ban on backdoor rebates. Okay, and so operationally, what I will be doing is I will use the empirical model and the estimates recover. I will switch off completely discounts. I will set them to zero, and I will allow manufacturer to set new prices, new optimal prices, and physician practice to make new choices of vaccines. And what's the overview of the results of my finding? Let's go to next slide, please. Okay, so what is the result? So in my setting as list, under a discount ban, manufacturer will tend to set higher prices, okay? So the newly optimal prices will be higher than the discounted one. So practices that were relying a lot previously on discount will end up paying more. This means that some of the practices will be now more likely to reduce their purchases of optional vaccines, the ones not required for kids to enter school and thus more, difficult to predict in terms of uptake. A second dimension of change in practice choices is that practices will be more likely to choose the cheapest brand if two options are available for the same diseases. But cheaper brands in the world of vaccines and looking at clinical trials data typically means lower efficacy and higher adverse effects. So what's the takeaway from simulating a discount ban in my setting is that patients and practices will be worse off, insurers will be better off, at least in the short run, and there will be a mixed impact on manufacturers. For example, GSK will be worse off after a discount ban, since discounts really help GSK to expand the sales of its optional vaccines. Okay? And let me close my presentation with a couple of conclusions. So what I've been doing here is I studied the welfare effects of bundle loyalty discount contracts for physician-administered treatments. I use immunization as a prime example of these contractual arrangements because we learn from antitrust cases that discounts are commonplace in these settings. And I believe that this result has important implication for both antitrust policy and health policy in the following sense that what we learn, for example, is that a strict antitrust enforcement, for example, via a ban on discounts, will translate in potentially negative effect for kids' uptake, and especially so if this is combined with a relaxation on vaccine requirement to enter school. Okay, and with this, thank you so much for listening, and I'll leave the floor to Maggie.
Oz, fantastic. Thank you so much, Chiara. I really appreciate so interesting to see what you've been doing with the data and see some of those first results for the research come in. There I am, sorry. So with that, we will go ahead and turn it over to Maggie. But if you have any questions for Chiara from that presentation, all lines are muted, but there is a chat box. So please go ahead and type any questions that come to mind into the chat box, and we will try and make some time at the end of today's presentation to go through any questions that we receive. And then as well, we will have her information and contact information at the end of this presentation so you can reach out directly if your question doesn't get answered today. So please send in your questions. And as you do that, I will turn it over to Maggie, who is going to take us through everything you need to know about the new data vendor for the Colorado All-Payer Claims database.
Amazing. Thank you so much, Sarah. Thank you so much for the presentation, Chiara. It's so amazing to see CO APCD data and work. So I'm really excited to talk to you all today about the vendor transition. My name is Maggie Mueller. I'm the Director of Data Operations and Development here at CIVHC. I oversee a couple of our production teams and I'm the primary vendor liaison for our company, and there's a lot to go over. Next slide. This is a high-level overview of what we're going to cover today, but we're really going to be cruising through that 10,000-foot view of the transition. To go into all of the details would take hours, and we're going to hit on some key points that are really relevant to our data users. There'll be more information in these slides than I can cover in the time that we have, but you'll have these slides. We have a blog post for updates on the transition, and our website and our newsletters are great ways to stay informed. So definitely stay in touch with those so you can be up to date on when things will be available. Next slide. Love to introduce our new data vendors, Onpoint Health Data. Really excited to be partnering with them. They're an industry leader for APCDs in the country. As you can see from this map here, they partner with different states in a variety of ways. And all of those states in that darker gold shading are ones where they provide the primary data vendor services, as they do now for us. So they have a lot of experience in this field. We're really excited to be able to learn from what they have been learning over the years, and leverage some of the industry best practices for us to take Civic and CO APCD into the next phase of healthcare policy and growth and development. Next slide. So a little recap. This is a high-level timeline of what has occurred over the last year in transitioning our data vendor services. We executed our contract with Onpoint beginning July of last year and worked in that first quarter really to lay the foundation project plans and build out. Our submitter portal was open for testing in November, and that's about the time that we also started initiating some claims transfers. We were able to move to full production submissions from our amazing submitters. They worked in collaboration with us. We're very grateful for all the testing they did to get us all ready to go for February. We've been receiving production submissions from our submitters since February of this year. In April, we were able to conclude the transfer of over 1 billion claims of data for commercial and Medicaid payers, which is a huge achievement, and a lot of different efforts go into that to ensure the security and safety and integrity of the files transferred across vendors. And we most recently in July had our production refresh with Onpoint as our primary vendor. And that was a huge milestone. We're really excited to be working with the data in new and novel ways. Because we're a data organization, I'm going to pull out some data points on things that we've done this year. As I said, over 1 billion claims have been transferred to date. Over 30 terabytes of files, analytics, folders, support documentation that live within these secure environments was transferred. 10 years of analytics creates a lot of documentation. So we've been able to move all of that. Over 1 full-time employee equivalent was the amount of hours logged by our teams. And doing all of this, we still increased our output last year by 21% to best serve all of you and make sure that we were meeting the needs of our data users and researchers. Next slide. So there's a lot of change, and we all know this already. Change is both good and hard. It's never something that comes easily, but a couple of key things on why this is a good change for Civic and the CO APCD. It really lays the foundation for a more scalable environment. As I noted earlier, those industry best practices and standards allow us to continue to innovate with partners across the country. And really making this investment allows us to focus on how we best leverage workflows for our data users and for our for the folks who are using this CO APCD information to be able to inform decisions around healthcare. It always is difficult, and so we're not going to just gloss over some of those pieces. There are going to be new terms, new data layouts, new structures for us all to learn. We'll have new reference documentation to update for you all, so that will replace our old documentation. And then it's going to take adjusted timelines, not just for production side from Civic to be able to produce products and the data licensing that's going on, but then also on the back end, folks who've been working with this data for a long time. It's going to take a little bit longer once you receive it to make sure that things are looking as you expect, get used to the new environment, or the new structure. It's a real transition, not just like going from a Mac to a Windows and you're still working with your files. You got to work out a few kinks, but more like everything about the structure has been shifted, and that's going to set us up for long-term success, and it's a short-term growing pains for sure. Next slide. So what's not changing? There's a lot of things that will remain consistent for our data users, both internal to Civic and our external users, and we'll still have the same amount of data available for you all, not just the years, but the data types, be able to have access to that. because our underlying submissions are based on our data submission guide, which remains consistent, and those regulatory changes are enforced on an annual basis. The underlying use cases that CO APCD data can inform will remain the same. You'll still be able to come to us with research questions, with policy questions, and be able to get data that supports getting more accurate understanding of what's going on in the underlying population in Colorado. We'll continue to have post-delivery support, expanding that a little bit. I'll talk about a little bit later. And the data request and application process will remain the same. Geocoding is a really key thing that I think a lot of folks, I know a lot of folks use in our data from our data users. And so we're using the exact same software, that GeoCodio, as a baseline. So those functions will remain consistent. And what you can get from Civic, data sets, custom reports, public data on our website, those underlying data files, dashboards, evaluation insights, research support. Those are all things that will still be available. And our goal in the long term is to be able to be even more expansive in how we're meeting the needs of data users and toy with ideas that allow us to innovate in ways that better meet specific needs because use cases for data like this are ever expanding and ever changing. So we want to be responsive to that. And then our group, there's always going to be value adds. We have our DRGs, our APR DRGs. Those are all some specific examples for you. Next slide. So what has changed? As I mentioned, these first three bullets really take us through the life cycle of our data. So the submissions and intake processing platform has shifted, and then our underlying business rules are different. And those business rules are vendor specific. That is something that is applied based on the methodologies and best practices that every vendor has and develops over their own expertise. And what we have with Onpoint, we are using as our standard foundation. And over the last year, we've been adjusting our processing, tweaking things in ways that make the most sense for the unique ways in which Colorado uses this data, but our core structures have shifted. And that's going to be a learning curve. It has been for all of us. And so we're excited to meet that challenge and also recognize that it's a big difference. Because that underlying data structure shifts, the final output is different. So table names and ways in which that's organized will be updated. When we think about that now at a more granular level, those elements themselves have shifted as well. And so our data element selection form, that DESF, which is how our users indicate what they would like included in our data sets, in the data sets they receive, those are shifting. And we are doing a lot of work on the back end to ensure that crosswalks and documentation are available for everybody who's using this data so that you continue the robust analytics that are in progress. We'll talk a little more about all the documentation coming at the end. And another key component is the warehouse refresh time. This is not as relevant for all users, but for folks who are looking for specific updates, recurring clients or refresh data based on what is now available. In the past, we've had our warehouse refresh in the middle of the month. For example, last July, it was July 14th, and then now will be towards the end of the month. This year, it was July 23rd, last Thursday, we received our updated July refresh. One of the changes that I'm most excited about is having exclusively Civic-led development of all of our data products. Historically, we have leveraged the expertise of our legacy vendor to support data set construction and liaison with them on how best to meet the needs of our data users. And this was all being brought in-house for Civic. So Civic will have production end-to-end touching points on every aspect of our development, as opposed to oversight and review on some of them. So this is really exciting. It allows us to continue to innovate and be a little more nimble in our responses to our users' needs. Next slide. The why, we've touched on a little bit, but it's a lot. After you look at what has changed, kind of these big picture ideas, I'm sure there's a couple of folks who are like, oh my goodness, this feels like it's huge. It is a big change, but the why I think is really important too. So this was not made lightly. Our vendor selection process really kicked off in 2024. And so we have been in this vendor transition world for quite a while now. And after a really thorough and competitive RFP process, comparing all of the different options that we had from the amazing vendors, going with Onpoint allows us to really meet the future of healthcare data analytics and policy engagement, research engagement. We think that the scalability options that are a little easier to align to the common data layout, which is that intake format, and the increased oversight that it has on all data products will allow us to, like I said, be more nimble and responsive to all of the changes that are happening at a rapid pace in healthcare these days. The other key component is that CIVHC and the CO APCD have grown substantially in both size and complexity in the last 10 years. And when we think about all of the different work that's occurred over the last decade, there have been some amazing developments, a lot of progress made, great innovation that happened. And we've gotten to a certain point of how do we now pivot? A lot of conversations in healthcare, how do we make the most with what we have and we understand what policy implications are as quickly as possible so we can support our patients and communities as best as possible. To do that, we definitely need that scalability. We need that nimble responsiveness. We need that innovative edge. So the why in the long term really sets us up for great success to continue not only to support all of you, but to the fundamental charge of supporting healthcare and making it more transparent, affordable, equitable. And this really sets us up for that. Next slide. So for data users, for all of you, what are some things that you will have available in support of this transition? First and foremost, I want to call out to stay updated with all of the different documentation pieces and support resources that we will have coming out. Stay connected with us through our website, through our email updates, through these research showcases. There's going to be a lot of information coming out in waves as we continue to develop and build our own understanding and refine the structures of this documentation. So definitely stay connected with us. We will have an updated data element selection form and crosswalk documentation for use so that folks are able to understand changes that have occurred and select the most updated data elements. That also include data dictionaries that contain the same level of detail that we have historically provided, the dimensions of elements, support for, which really support creation of databases for those users receiving a lot of data and wanting to work with it over a long period of time. We will continue to support in a more dedicated way those subscription users, folks who are coming on a regular basis to receive those updates. How do we make sure that you're able to continue your analytics across time and across this vendor refresh? As always, we will have release notes after our warehouse updates, and so that will include updates that we've made, changes, data quality notes, things that are available to help influence and inform the best practices and understanding of the very complex and nuanced data that is claims data. Definitely come back to these research showcases. We'll want to have lots of opportunity for ways in which our teams have been leveraging either the new functionalities or continuing analytics across time to really help support use cases for you all. I mentioned briefly expanded support. We have a process internally, it's a 411 team, and that is where our post-delivery support, you're working with your data set, you're not quite sure what this field should mean, something looks a little bit off. You reach out to your contact and we field that question, investigate it, write up a summary for you to try and continue to inform best practices. We're expanding this process and this team so that we can continue to meet this need. We know that there's going to be an increase in questions as we move through this transition into our production. We're really excited to be able to continue to leverage that support for you all. Next slide. I do want to note that there our data documentation is still in progress. There's a few reasons to that. I want to be transparent about why that is. Our warehouse refresh that came out last week really was part of getting us the production data for us to be able to then now leverage that for reporting and data sets. And in order to have the most accurate information to present to all of our data users externally, we wanted to be able to be sure of what it is that we are understanding, our interpretations of the data, working collaboratively with Onpoint to ensure that that's correct, because we know that this is a big change and we don't want to race through to provide documentation that may cause more confusion without that underlying certainty. So we've been working diligently through that, and the collaborative relationship that our data users you all have with Civic is invaluable. So we hope that you will continue to send us questions, identify areas where you would like to see differences, or you're noting things that don't look quite what you would expect, so that we can all better understand how to support each other. The only way to understand data is to use data, and the novel ways in which all of our researchers and partners use data help inform improvements and progress in CO APCD structures and for Civic. So we're very grateful for this partnership, and we hope that this continuing collaboration really supports the overall growth and trajectory of CO APCD use cases. Next slide. This looks incredibly complex. I'm not going to go into all of these details, and also in a recent blog post, and you'll be able to dig into this. The headline from this piece is that Medicare fee-for-service data follows a different trajectory for sharing and for management than commercial and Medicaid data does. I think most of you know that, and the process is governed by a very specific sequence of approvals and documentation. So Medicare fee-for-service data is not currently available for licensing. It will be available later this year. We are moving through that process as quickly as we can, but stay up to date with your Civic contacts and with all the different ways in which you interact with Civic to know when that is going to be fully available. Next slide. It was a lot. It was a high level, rapid fire info. There's a couple of questions here for consideration. And if you want to ask questions that are related to these, or if you have comments, we would love to hear them either in the chat, in the few minutes that we have for Q&A, and in all of the different ways in which you can get in touch with us. There's a lot that we want to make sure that we are doing to support you all, but you all are also the best resources to know what you need. So definitely engage with us. Let us know. We want to make sure that we are being responsive and that we're all balancing as best we can in this period of transition with CO APCD data and Civic. So thank you so much for the time. I'm really grateful to have the opportunity to speak with you all, and look forward to any questions.
That was fantastic. Thank you so much, Maggie. A lot of information to go over, but we are really thrilled to be partnering with Onpoint. So I am going to leave a couple of minutes here for anybody to type your questions or comments into the chat. So you can respond to any of the discussion questions that Maggie has posted here, or if you have any additional questions, please go ahead and post them at this time. And while I'm giving everyone just a couple of seconds to do that, I see some comments coming in from Lori. Thank you very much. I'm just going to drop a couple of links here for you very quickly. First, this is the link to the blog that Maggie mentioned, all about the CO APCD data vendor transition. I'm also going to go ahead and drop my email in the chat. I run the CO APCD data brief, and this is our main method of communicating with data users about all things CO APCD data analytics and quality. And that is where we will be posting, as well as on the website. We'll be making sure to mention in every data brief when new resources that Maggie talked about become available. So please go ahead and shoot me an email if you would like to be a part of receive the CO-APCD data briefs. They're every other month. There is my email. And with that, see a couple of comments and questions from Lori. First one is for Chiara, if you're still here.
Of
Um,
course.
Awesome. So I'm just going to read this out loud, best I
Sure.
can here. Um, Lori says, it would be interesting to see how your model works in the 11 VFC states, where the states pay for all vaccines, including Medicaid and commercial. The cost of vaccines and the risk and cash flow required to manage vaccine inventory are top issues for pediatric and family practice offices. Also, further analysis studying the cost of vaccine versus the reimbursement, many practices don't keep up their contract negotiations and are being compensated below the cost of the vaccine, even with vendor discounts. And she says, thank you for your work. Thank you for your comment, Lori. Um, I'll leave it open to you, Chiara, if you have
Yeah,
anything
of
you'd like to
course.
respond with.
Super briefly. Thank you, Lori. This is super on point. I totally agree that the Vaccine for Children program deserves separate attention. I'm working on some simulations that focus on that. The work that you saw today was mostly focusing on commercial payers. For those of you who aren't familiar with that, the Vaccine for Children program is a program that affects around half the children population that receive basically vaccines that are purchased by the government, that buy directly vaccines from manufacturers and then distribute those vaccines for free to providers. So for providers for those vaccines do not have to pay basically and are not reimbursed for the vaccines. They just bear the cost of storage and so on. So I think it's super important. It would be cool to see the spillover between the Vaccine for Children program and commercial payers. Totally agree with you.
Awesome. Well, thank you so much, Chiara. I'm nodding along here, just understanding every other word, but very interesting. And I saw Lori had another comment that it looks like Maggie has addressed in the chat. Thank you so much, Maggie, and thank you so much, Lori, for your comments. We've got about 8 minutes left, but we can end early unless there are any other questions. I'm just going to leave it open for a minute or so here, to see if anybody has any additional questions, comments, or anything that they would like to share with our presenters today. All right. And if you wake up in the night and realize that you had a question that you didn't get to ask or something comes to mind, please feel free to reach out. Chiara's information is shared in this presentation. This presentation will also be posted on our events resources page early next week, I believe. And additionally, you can reach out to us with any questions regarding the data vendor transition or anything else that Maggie shared at info@civic.org. I will drop that in the chat. And finally, before we close off today and give you all 5 minutes of your day back, please consider joining us for our next research showcase we will be having in September. We will hear from some more researchers who are doing great work out in the field using CO-APCD data. So I'm dropping the link. Oop, there we go. It's a long link, but there is the registration link in the chat. So please go ahead, join us in September. Please reach out with any additional questions, thoughts, or anything else. And with that, I will give everybody 5-ish, 6-ish minutes of their day back. But thank you all so much for joining us for our presentation today. I hope you learned something valuable, and we'll see you all in September at the next one. Thanks all so much. Have a great rest of your day.